So welcome back everybody. This is the part 2 of my presentation, which is the Maryland Bridge. So it's a conservative restoration alternative for the missing maxillary anterior teeth, right? So the purpose of putting those missing teeth is to build up the confidence and the beautiful smiles which patient has lost due to the missing teeth. So when we see any teeth which is absent, we have the conventional treatment of crown and bridge, in which we give the full coverage restoration, the full coverage crowns, and we have to prepare the abutment teeth, and then we can replace the abutment. We can replace the missing teeth. Right. So treatment option include the crown and bridge. Say, for example, if we have a maxillary lateral incisor messing up, so we have the conventional crown and bridge treatment. But the thing is, we have to prepare the maxillary central and the canine for replacing a maxillary lateral incisor. So Maryland Bridge or the Rochet Bridge is a tested and tried method for replacing the maxillary lateral incisors. So Rochet bridge is basically a perforated bridge which can be made out of ceramic, which can be made out of metal. And Maryland bridge is basically an electrolytically etched bridge which can be placed. So the advantage of using a Maryland bridge over a conventional bridge, it gives the it gives the uh, advantage of preserving the existing tooth structure of the central and the canine. It is reversible. You can remove the prosthesis and you can any day put your implant or give whatever treatment. It is aesthetically pleasing also, and less chair side time is required in comparison with the conventional treatment, and it is very cost effective. Disadvantage, it is very technique sensitive and it can't be used on broken down teeth. Broken down teeth in the sense, the if the central incisor has undergone a root canal treatment and it has a crown, or say a canine has been broken down and it is built up with composite, so you cannot give a Maryland bridge on those teeth, and there can be graying or the see-through of the metal in between the line angles and the point angles, and there can be graying effect. So factors for the success of cases that are treated with Maryland Bridge is basically case selection, the general design, that is the anterior design of the incisor where it is to be placed, the choice of the metal or the ceramic, the fitting of the bridge, the placing of the bridge, and the recall and the review of that particular case. So case selection, any lateral incisor missing in which the central incisor and the canines both have sufficient enamel. So both of them can be prepped and you can give a Maryland bridge. There will be mobility. If there is mobility of the abutment teeth, you cannot use both of them, right? So occlusal clearance of 0.5 mm has to be prepared on the canine and the central incisor for placing a Maryland bridge. So general design, a framework is fabricated. The purpose of making a framework is to provide the support for the pontic, which is the missing teeth, the limit the stresses placed on the luting agent and bonding interface, and increasing the enamel available for bonding and provide the resistance on the withdrawal. So general design of a pontic, general design of a pontic should be ovate. In cases of Maryland bridge, you have to create a pontic emergence, so it should be aesthetically pleasing. There will be wings that will be placed on the central incisor and the canine to replace the lateral incisor. This is how the impression is made. You can see this small amount of extension. Those are the voids that are made on the palatal surface of the teeth. So once you place your Maryland bridge over the existing teeth, you can appreciate that the frameworks is fitting well, and the only the palatal area on the of the cingulum on both the central and the on both the canines are covered. So receiving site on the edentulous ridge, as I said, it should enhance an aesthetic placement, and you should contour the gum line. So you can use your electrocautery and you can use a surgical option. So once you modify that pontic site, you can give something called as flippers. Flippers are nothing but the palatal blade, which is made out of say flexible resin, on which your acrylic PMMA lateral incisor are fabricated, and the patient can wear the flipper. So what happens after 4 months? You get an emergence, which is something like this. On the right side of your screen, you can see the image. So without modification, you can see how blunt the image is, the appearance is. And once you have prepared the emergence side, you can see how beautifully the lateral has merged with the emergence. So metal, there are various alloys that are available. Gold gave good results. Also, gold color produces better fitting restoration, the most malleable and the most ductile metal. So it reduces the occurrence of caries and the gingival inflammation. So trial to the purpose of putting up, just a second. The purpose of putting up the bridge before cementation is to ensure the aesthetic success. The fitting should be good, your color should match, your contour of the pontic design should match, the occlusion should be at par, and your graying should not be there. So at placing the bridge, the abutment teeth are thoroughly cleaned. The area is isolated and the abutment teeth are air dried. Enamel of the abutment teeth are acid etched, and that are etched with 30 to 50% phosphoric acid. And once the acid etched is done, the teeth are rinsed thoroughly. Resin is applied to the enamel and the internal portion of the framework, and it is followed by a dual cure composite resin that will adhere to the existing tooth structure. So in checkup appointment, you can see this partial debonding can occur without the patient noticing the looseness. So remove the bridge again, clean everything on both the central and the canine, and place a dual cure resin cement and again place it back. And ask the patient, motivate the patient to maintain the